Okay, بسم الله الرحمن الرحيم. الحمد لله رب العالمين. السلام عليكم ورحمة الله وبركاته جميعا. It's my honor and pleasure to be here with you today, and it's my honor and pleasure to introduce Dr. Basem Elbarouni, who is an associate professor at the University of Manitoba, Canada. He's a director of the Cath Lab, interventional cardiologist, and he will talk to us today about the right heart cath and hemodynamic assessment. Before that, I would like to introduce the expert panel, including Dr. Osam Halil, cardiologist from Libya, Dr. Muhammad Al-Ayyan, cardiologist from the USA. And by the end of this presentation, inshallah, we'll give a chance to the expert panel to say a couple of wisdom words. And then after that, we'll open it to questions and discussion, inshallah. Please write your questions in the chat box there, and you can ask them in person by the end of the presentation. And you can also raise your hand if you'd like to ask your question in person. From here, Basem, inshallah, I'll hand it over to you. You can start recording and you can start your presentation.
السلام عليكم، بارك الله فيك عبد الغني، وشكرا للحضور اللي يجوا ما شاء الله في عدد كبير جدا حاضرين. الموضوع اللي بنتكلم عليه هو الدسم هلبة، ويعتمد هلبة على الفيزيولوجي بتاع الكارديوفاسكولار، وفيها معادلات وحسابات، فنحاول نبسطها بأكثر ما يمكن. والموضوع طويل، صعب تلخيصها في ساعة بس، لكن على الأقل تكون introduction. في lots of resources online اللي بيزيد بالثقافة أكثر. نبدأ بكيس example. عندك patient جاي 63 female، المين complaint بتاعها shortness of breath and exertion، NYHA class 3. عندها history of hypertension لكن reasonably controlled. الechocardiogram showed the RVSP of 60 mm mercury. كده في الايكو جروب يشرحوا شنو هو الRVSP، لكن it summarizes the assessment of the right ventricular systolic pressure. 60 mm mercury is quite high, and there's moderate tricuspid regurgitation. Like in the left system, she has normal left systolic function and wall thickness, with only slightly enlarged left atrium. So the question comes to mind: is this pulmonary arterial hypertension or is this HFpEF? And in some cases, it's hard to tell clinically, and sometimes invasive hemodynamic assessment might be required to sort that out. Another example, you have a patient comes to the emergency department. He's 65. He has a known history of dilated cardiomyopathy. He's NYHA class 1 to 2 on furosemide. اسبوعين فات وصارت له برده, had decreased appetite, comes to the emerge now feeling unwell. And you examine him, he's hypotensive and his blood pressure is 70/40, with the normal blood pressure readings before that were normal. So what's the cause of his hypotension here? Someone who has a dilated cardiomyopathy but had decreased appetite. Sometimes by clinical examination, usually you'd be able to sort that out, but sometimes you need invasive hemodynamics to figure that out. Third case, a young patient on heart transplant list who's referred for scheduled to right heart cath. And why is he being referred? And we'll discuss that down the road. So the objectives of their talk, I'm going to review steps of a right heart cath, assessment of filling pressures and pulmonary hypertension. How do we measure the cardiac output? And then depending on the time, we'll talk about the assessment of intracardiac shunts, the use of right heart caths in valvular disease, and the assessment of constrictive pericarditis, which are important topics. Now, invasive hemodynamics used to be, back in the 60s, 70s, the way to assess and diagnose a lot of cardiac conditions. With the advent of non-invasive modalities, including echo and MRI, its importance and need has decreased quite a bit, but there are still cases where it's required. So how do we do a right heart cath? So it's use the venous circulation. The access could be from an intrajugular, and the central line, usually using ultrasound, or it could be from the femoral vein or from the antecubital vein. And this is my preferred method at this point. Usually you need a 7 French sheath to use the Swan-Ganz catheter. So this is what the Swan-Ganz catheter looks like. All right, it has a balloon at the tip that is inflated from this red port. There is a syringe that comes back into it. You can inflate and deflate, and you can lock it so that the balloon stays inflated. When the balloon is inflated, it allows it to flow. It becomes a flotation device, follows the bloodstream through the cardiac chambers. There is also a distal port, the one in yellow, that hooks up to the distal part of the distal end hole of the Swan-Ganz catheter. so that you can measure pressures and obtain blood samples from there. The blue port is a proximal port. When the Swan-Ganz is all the way to the pulmonary artery, the blue port will open up into the right atrium. And that's important when we talk about cardiac output. And then this piece here is a thermistor that can measure changes in temperature in the bloodstream. This is also important for cardiac output, and we'll talk about that later. So the device will be hooked up at the back to a pressure transducer. So pressure transducers transmit waveforms into the electrical waveform that we can see on the monitor. And usually you need cath lab software. The one we use is a MATLAB. So while the patient's in the cath lab, you have a technician sitting here monitoring the tracings, recording them, and the software allows to do all the different calculations and measurements. So I kind of capture screen this off of the Edwards website to show how a right heart cath is done. So you advance the catheter, in this case it's coming from the internal jugular, inflate the balloon while it's in the right atrium, and then just by advancing, usually the catheter will just follow and go up into the pulmonary artery. You could do this with fluoroscopy or by just monitoring the blood pressure changes. So that was in the right ventricle, and then it passes through the pulmonary artery and pulmonary valve into the pulmonary artery. And then if you advance it, it'll get wedged into the pulmonary artery, giving a wedge pressure. And we'll talk about that in a bit more details. But when you deflate the balloon, then you get a right ventricular pressure, a pulmonary arterial pressure. And then if you wedge it again, the pressure changes. So just playing that again. So the right heart catheter is in the right atrium. Inflate the balloon and then just advance, and the balloon will and the catheter will just float across the tricuspid valve. So here is in the right atrium, and then once it gets into the right ventricle, you get a right ventricular pressure waveform. Advance it further across the pulmonary artery, and it goes pulmonary valve into the pulmonary artery, and you get a pulmonary artery waveform. And then once it wedges, the pressure changes to the wedge pressure. All right. So essentially, there are 4 chambers: the right atrium, right ventricle, pulmonary artery, and pulmonary artery wedge pressure that we measure, okay? So we'll start with the right atrial pressure. The right atrial pressure is essentially the JVP. When you examine the JVP, you're examining the right atrial pressure. There is a wave and V wave. So we'll monitor with the cardiac cycle, or the EKG. The A wave happens when the right atrium contracts. All right, so that causes a positive pressure deflection. And then at the end of that atrial contraction, the blood has been emptied, systole happens. And when systole happens, the tricuspid valve closes, causing the C wave, a small increase in the pressure there that sometimes is apparent, sometimes not, but that's what it reflects. And then atrial relaxation happens and the pressure drops, and that's the X descent. So the X descent usually corresponds with just after the QRS and corresponds to the S1 on auscultation. And then during diastole, blood is coming back into the right atrium, so pressure starts building up at the right atrium and causing a V wave. And then diastole, and then the tricuspid valve opens up at the end of systole. Sorry, this is during systole. At the end of systole, the tricuspid valve opens up and blood goes into the right ventricle, causing a Y descent. So again, A wave happens with atrial contraction, and then at the end of the atrial contraction, the pressure starts dropping because it's been emptied, and then the tricuspid valve closes and the atrium relaxes. X wave happens, and the pressure, then the X descent happens. While blood is coming back into the right atrium, the pressure starts building up again, and you get a V wave for volume. And then once the tricuspid valve opens at the beginning of diastole, there is a Y descent where the pressure drops down. So you get you see an A wave and a V wave when you examine the JVP, and that's the right atrial pressure. Typically, it's around the mean pressure is around 2 to 5, and the A wave and V wave shouldn't be too high. And there's different pathologies that can cause those changes. This is the right ventricular pressure. So right ventricular pressure is similar to the left ventricular pressure, except it's at a much lower scale. So notice the scale here is from 0 to 30, while if we were measuring the left ventricular pressure, the scale would be from 0 to 200. You have Systole, contraction, and then diastole, relaxation. And then diastole starts and the pressure comes down, and you have a flat curve. Blood starts pooling back into the right ventricle, contraction, systole, and then diastole again. So it goes up and down. Pulmonary arterial pressure is similar to the waveform is similar to the aortic pressure, except again it's on a different scale from 0 to 30. So you have systole and then diastole happens, and the pressure, instead of coming down quickly like we see in the right ventricle, comes down slowly due to the elasticity of the pulmonary arteries. So you see a slow diastolic descent. Diastole starts usually from the D wave, from the diacrotic notch, which is the pulmonary valve closure. These are the normal values for the pulmonary arterial pressure. Pulmonary hypertension is diagnosed when the mean pulmonary pressure is measured as more than 20 millimeter mercury. It used to be 25. It's changed recently to 20 millimeter mercury. And then when the balloon is inflated and wedged in all the way, that will change the waveform to a pulmonary capillary wedge pressure. So what is that? So ideally, would like to measure the left atrial pressure if we can get into the left atrium. In some cases, you have to do that, but the only way to do that would be by doing a septal puncture. So you would have to puncture the septum and go into the left atrium to measure the left atrial pressure immediately, which comes with its own risks and skill level. All right. However, the left atrium, if we wedge a balloon into the pulmonary artery, the tip of that balloon beyond the occlusion is now in continuity through the pulmonary arteries, capillaries, pulmonary veins into the left atrium. So you can actually measure the left atrial pressure from here once you've wedged the balloon in and blocked the pulmonary artery flow or pressure waveform. So this is what a wedge pressure would look like. Exactly like the right atrial pressure, there is an A wave and a V wave. There's two differences with the wedge pressure compared to the right atrial pressure. The first is that the amplitude of the A wave and V wave is a bit higher. That's because the left atrium is a bit more stiff, less compliant, dealing with slightly higher pressures. The other important thing to note here is the A wave onset on the wedge pressure. Remember, the A wave is atrial contraction, but notice that the P wave is here and the atrial wave is here. The reason for that is because of the delay in transmission of pressure from the left atrium all the way back to the catheter. So this is important when we're doing simultaneous pressure measurements, that this has to be adjusted by the technician to get proper measurements. And usually a mean wedge pressure normally would be 4.5 to 13 millimeter mercury. It's important to note that when we're measuring the pressures in the right circulation, the variation in the intrathoracic pressures with respiration causes a lot of swinging in the pressure waveform. We really would want to measure the pressure waveforms at the end of expiration, because that's when the intrathoracic pressure is zero, not negative or positive, end of expiration. So in this example of a wedge pressure, you can see that it's going up and down, and we see this in the lab. Same with the pulmonary pressure, goes up and down. I want to try and measure that at end expiration. Or what I like to do is to ask the patient to stop breathing. So I tell them to take a deep breath in, breathe out, and then just stop breathing for a few seconds, and you get a linear waveform that's easier to measure and report. So those are the four chambers and their pressure waveforms and what they normally look like. So next part, I'm going to talk about cardiac output. So cardiac output is defined as heart rate multiplied by stroke volume, but we can't really measure stroke volume, at least not easily. Instead, the way to measure cardiac outputs include either the Fick equation or thermodilution. And فكروا في الفسيولوجي متاع السنة الثانية, this is what we're going to go back to again. So Fick equation is a bit challenging, all right? But I'll try and walk you through it and try to simplify it. The oxygen consumption, how much oxygen does the body use up, is equal to the oxygen amount delivered to the organs minus the oxygen amount that's returned to the heart. All right, sounds simple enough. كمية الأكسجين اللي بيستخدمها الجسم هو is the oxygen that was delivered minus the oxygen returned to the heart. So what is the oxygen that's delivered? So the oxygen delivered is the cardiac output multiplied by the oxygen content. And how much oxygen is in the blood multiplied by how much blood is delivered, all right? So VO2, we'll call oxygen consumption VO2, is equal to cardiac output multiplied by the oxygen content in the arterial blood minus the cardiac output multiplied by the oxygen content in the venous blood. All right? Sounds good so far? So VO2 is equivalent to the cardiac output multiplied by the oxygen content in the arterial blood minus the oxygen content in the venous blood. Okay? رياضيات يعني المعادلات. So طرفين في الوسطين, we can say that the cardiac output is equal to VO2, oxygen consumption, divided by the oxygen content in the arterial blood minus the oxygen content in the venous blood. Inshallah قاعدين معي. So what is oxygen content? I've talked about oxygen content. Oxygen content معادلتها 1.34, which is a constant, multiplied by the hemoglobin, and the hemoglobin is what's going to carry oxygen, multiplied by the oxygen saturation. How much is the hemoglobin saturated? Okay. And if we take this out, that means that VO2, عوض oxygen content CO2 equals 1.34 multiplied by hemoglobin multiplied by the systemic oxygen saturation, which is going to the arterial blood saturation, minus the mixed venous oxygen saturation, which is the venous return to the blood, okay, to the heart. Okay. Okay, so this هذا هو وصلنا المعادلة. Cardiac output equals VO2 divided by 1.34 hemoglobin multiplied by the difference in the oxygen saturation, systemic minus mixed venous. Okay, so what we need is we need to know what VO2 is. So VO2, oxygen consumption, is estimated. It's not something that's measured. There are ways to measure it, but usually most labs, the majority of labs don't do that. It's estimated. So there's tables depending on the patient's weight, height, age, and gender. It will give you what the VO2 max is, VO2 consumption is, or the oxygen consumption at a resting state, which is what you're doing in the cath lab, okay? Divided by 1.3. So VO2 is estimated. And then you need the hemoglobin. When you do oxygen saturation, the device will also give you the hemoglobin concentration. So make sure that the hemoglobin measured in both samples are similar. Okay, so that's how you get the hemoglobin. سهلة. Systemic oxygen saturation can be measured either with a blood sample. If you're doing a left and right heart cath, you can do a blood sample. You can take an ABG, or just with the oximetry, which is what I usually would do. Finally, the mixed venous O2 sat. You just take a blood sample from the pulmonary artery, because the blood comes into the right atrium from the IVC, the SVC, the coronary sinus, gets mixed and pumped to the pulmonary artery. So if you take a pulmonary artery oxygen saturation, then you have the mixed venous there. Okay, and then you plug that into the software, and it'll give you the cardiac output using the Fick equation. Okay, hopefully you haven't lost you there. Okay. So that's the Fick. Thermodilution is a different method of measuring cardiac output. Okay. Now remember, I said that when the Swan-Ganz catheter is all the way to the pulmonary artery, the blue part will be in the right atrium. So if we injected a cold solution or colder solution into the blue port, it'll go into the right atrium, mix up with blood, and then travel to the pulmonary artery. And at the tip of the pulmonary artery, there is a thermistor, this device here, which hooks up to a special connector that can measure the changes in temperature in the blood. Okay, so the method to do this, I just would take a 10 cc of normal saline, doesn't have to be cold, just room temperature, inject it, it'll transmit over there, and mix up with blood, and the change in blood temperature will be picked up by the device and plotted over a screen. Over a screen. So it'll be over time and changes in temperature. A normal cardiac output will look something like this, goes up and then goes down, and then it'll give you a number depending on the area under the curve. Okay. If you have a low cardiac output, meaning there is a lot less blood going through, that means that the change in temperature would be much slower. And this curve will give you a low cardiac output. On the other hand, if you have high cardiac output, the solution that you inject will get mixed up and moved on quickly. So the changes in temperature over time will be much shorter. For thermodilution is a bit more time consuming. You have to do it 3 times, and all 3 have to be within 10% of each other to be a good reading. All right, so 2 methods. The FIC is quick and easy. You just need to take oxygen saturations, which you should be doing anyways. Small errors in the oxygen saturation measurements can lead to errors. And VO2 is estimating and assumes a resting state. So if someone's got a fever or hyperthyroidism, for example, it might not be accurate. Thermodilution is more time consuming. It's also not very accurate and very low or high cardiac outputs. And most importantly, in patients with tricuspid regurgitation, there is more blood getting mixed up with the solution that is actual cardiac output. So it will give you a wrong reading. So it's usually not useful in that situation. Okay, so steps of the right heart cath. It's quick and easy usually. All right, you get access depending on what the method. And what I do, I go all the way up with the balloon inflated into the wedge position. I then deflate, aspirate, clear this line of any, and get a blood sample right away. So I'm in the pulmonary artery. I'll take the blood sample, give it to the nurse, and then they'll put it in and tell them what I think the arterial saturation is, and that way I get the cardiac cardiac output using the FIC equation. I then make sure that my 0 is good. The waveform, like remember the waveform being transmitted has to be leveled, and once it's leveled, I'll measure the pulmonary artery, the pressure. I'll take that waveform. I'll then pull the catheter back a bit, inflate the balloon, and then push it forward again to wedge. And that's important, and I'll tell you why. Then I'll get the wedge pressure. Okay, make sure that it's there's no movement, and then come back, take a right ventricular pressure, and then come back into the right atrium and take a right atrial pressure. And that's the basic what I do for a right heart cath, assuming there are no other questions in terms of shunting or constrictive pericarditis, because those are special techniques that we'll get into. The procedure itself is generally safe. The risks are very low. The most serious complication that you can have is pulmonary arterial rupture. I've seen this once, and it was fatal. And that happens when your Swan-Ganz is distal into the pulmonary artery, and you inflate the balloon to wedge. And that's when that can happen. So that's why I say it's important to make sure that you pull back the catheter before you inflate the balloon to wedge again. That keeps it safe. Arrhythmias, you're going through the right ventricle. Complete heart block can happen in patients who have a bundle branch block, especially a left bundle branch block. A PVC might cause transit right bundle branch block as well, leading to complete heart block. Very rare, but can happen. If you're going through the IJ, pneumothorax and carotid injury are always risks. So you should be using ultrasound. That should be a routine now to get to cannulate the vein. And then bleeding and embolism or other potential complications. When you take if you're going through the IJ, when you pull the sheath out, make sure that you ask the patient to take a deep breath in and hold before you do that to maintain a positive intrathoracic pressure to prevent air embolism. So back to the couple of examples that I mentioned earlier on. So 63 female, shortness of breath and exertion, history of hypertension, and it's controlled. The echo shows RVSB is elevated. So you're questioning, is this all elevated because of the elevated left atrial pressure, or is it true pulmonary arterial hypertension? And just to go into the pulmonary hypertension, I'm not going to go into these details, but there are 5 types. The first type is the type 1 pulmonary arterial hypertension, idiopathic. You also hear the term precapillary hypertension. Type 2 is due to left-sided heart disease. Any cause of elevated pressures in the left side will cause elevated pressures in the right side. We'll talk about that. Type 3 is due to chronic lung disease, COPD, or interstitial lung disease. That's also would be usually precapillary. Type 4, patients with chronic pulmonary thromboembolism. Also, it would usually be precapillary, and then type 5 would be mixed or unknown. So back to this diagram. So let's say you're in the pulmonary circulation, you take a pulmonary arterial waveform, and it shows that the pulmonary pressures are quite elevated. All right. So what we're trying to decide here is that elevation because of an elevated left atrial pressure. Someone has left heart failure, has an elevated left ventricular end diastolic pressure, leading to left atrial pressure being elevated. That goes into the pulmonary vein, pulmonary veins and the capillaries into the pulmonary circulation and causes pulmonary hypertension. Patients who have left heart failure, you examine their JVP, examining their legs for pedal edema. That's because left-sided pressure will cause left-sided failure will cause elevated filling pressures on the right side and cause those changes as well. So obviously the management is very different than if it was pre-capillary. So let's go to the, unfortunately I couldn't find any waveforms for these cases, but let's say scenario 1. You measure the PA pressure and it's 35 millimeter mercury. So the PA pressure is 35, and remember normal is 20. So this patient does have pulmonary hypertension. However, when you wedge the catheter and get your wedge mean pressure is 24 millimeter mercury. Remember, normal was 13, so this is quite high. And if we calculate the transpulmonary gradient, which is the gradient across the pulmonary circulation, TBG, that is and it's calculated by PA mean pressure minus the wedge pressure is 11. And a transpulmonary gradient of less than 15 tells you that the elevation in the pulmonary pressure is not fixed, meaning it's not due to the pulmonary circulation, but rather because of the venous congestion. All right. And let's say in the same scenario, you calculated the cardiac output. If you divide you can calculate the pulmonary vascular resistance. How much of that elevated pulmonary pressure is due to actual pulmonary resistance? Okay. And the pulmonary vascular resistance is the transpulmonary gradient divided by the cardiac output. زي التيار الكهربائي فرق الجهد equals التيار مقسوم على التيار مقسوم على المقاومة. نفس الشيء هنا يعني. المقاومة is the فرق الجهد مقسوم على شدة التيار. So PVR equals transpulmonary gradient divided by cardiac output. In this example, the PVR was 11 divided by 5 equals 2.2, and this is reported as Wood units. And a 2.2 Wood units is normal. In this case, normal is less than 3. So in this case, if we reduced the wedge pressure, which is which is a reflection of the elevated left ventricular and diastolic pressure, we would expect that the PA pressure will come down as well. And this is a case in this case would be HFpEF because of diastolic dysfunction. And that's why there's shortness of breath. Let's change the numbers a bit. Let's say the PA pressure was measured at 50, but the wedge pressure was 10. So this means that all that PA pressure, which is very high, is not generated by the left atrium. It's mostly due to pulmonary vascular resistance. 50 minus 10 equals 40. So there's a very high transpulmonary gradient. And the cardiac output, let's say in this case, is 4. We calculate the PVR, and it's transpulmonary gradient 40 divided by 4, and that equals 10. And this is very high pulmonary vascular resistance. So this would be this would be a precapillary pulmonary hypertension. The other types, type 1 if there's no history of lung disease or thromboembolism, and 3 or 4 if those cases are present. Sorry, I kind of got there. So let's get to the second case. 65 male with known dilated cardiomyopathy. Has NYHA class 1 or 2 and furosemide. As I mentioned in the presentation, he had a recent viral infection. He decreases appetite and now comes in hypotensive. His blood pressure is 70/40. So there are two possibilities. He could be very dry because he has been decreased his intake and he's on a diuretic, or it could be that the viral infection causes cardiomyopathy to decline and now he's in cardiogenic shock. Okay. Now, usually you'd be able to sort these out with history and physical examination, but it's not always the case. And in some cases, you might need more information to be sure, especially if they're not responding to the treatment that you think is the right one. So let's say in this case, we took a PaO2 sat and it was 50%. Now, I forgot to mention the PaO2 sat in itself is a very good estimate of tissue perfusion. So normally, the heart delivers blood with oxygen to the organs. They'll take the oxygen they need and send the rest back to the heart. So the PaO2 sat is usually around 70%. Doesn't need to take that much out. However, if the heart's delivering a low amount of oxygen because of poor cardiac output, then the venous return, the blood that's returning to the heart, is low in oxygen content. So PaO2 sat of 50% in itself is a very early sign that your cardiac output is poor, or at least your tissue perfusion is poor, and it's extracting more oxygen. So let's say the PaO2 sat was 50%. Your mean PA pressure was 9, which is low, and the wedge was 8, and your cardiac output is 2.5 liters per minute. So your PA pressure is low, your wedge is low, your PaO2 sat is low, and your cardiac output is low, but this is mostly driven by low filling pressure. So the patient, you need to stop the diuretics and give this patient normal saline or volume to fix the hemodynamics. Let's say he still had the same PaO2 sat, 50%, but in this case, his PA pressure was 40 and his wedge was 30. So he is wet, and he has a very high filling pressures on the left side that's transmitting to the pulmonary circulation, and the cardiac output is also low. So in this scenario, if you give fluids, you're going to make things worse. The hemodynamics are going to get worse. You need to get rid of that fluids, and in the meantime, support the patient with inotropes or an inodilator such as dobutamine. Third case, young patient on heart transplant list referred for a scheduled or routine right heart cath. So if a patient's on a heart transplant list, they will routinely have every 3 months or so, while waiting for the transplant, get a right heart cath. And it's important to make sure that their pulmonary pressure and pulmonary vascular resistance is not high. Because if you take a new heart that is from a normal donor and put it in someone who has a high pulmonary pressure, that right ventricle is not used to that and hasn't adapted to it and will fail very quickly. So usually patients who are waiting for a transplant will come in routinely to make sure that their transpulmonary gradient is low, that their filling pressures are reasonable. And if they do get called in for a transplant, we'll always have to do a right heart cath right before their transplant to make sure that they're optimized for that. All right. I hope I haven't lost people yet. And, we can go back afterwards during the Q&A to try and go over those in a bit more detail if it's not clear. So now I'm going to change gear towards shunts. So what are shunts? Shunts are, so that's the case scenario, 35 female with shortness of breath and exertion. And when you do an ultrasound, you see that there's a dilated right ventricle. The quality of the picture is not great, but you suspect there is a shunt there. And a right heart cath is requested to try and identify where and what the shunt is. A shunt is a connection between the left and right circulation, leading to blunt shunting between circulations, either mostly left to right, and then some conditions right to left shunting would occur, but we're not going to get into that because that's a bit more complex. Examples include VSD, ASD, anomalous venous returns, congenital ASD or VSD. Ischemic VSD is kind of more of an emergency. The majority, as I said, are left to right shunts. The left circulation is higher in terms of pressure, so the blood will escape to the right side. Right to left shunts happens mostly in congenital patients or patients with Eisenmenger who have a shunt that have developed pulmonary hypertension. All right. So what do we do in the cath lab for a patient who's referred for a shunt assessment? So we could do a shunt run and calculate the QP to QS. All right. So we'll go over the shunt run first. So a shunt run, basically, when I explained to you what I do with the right heart cath, I only took one blood sample from the pulmonary artery. But when we're doing a shunt run, we have to take multiple samples from different chambers. At a minimum, we should take a sample from the pulmonary artery, from the right ventricle, from the right atrium, from the SVC, and from the IVC. All right. Most books will recommend that you take one from the left pulmonary artery branch, the right pulmonary artery branch, the main pulmonary artery branch, 3 from the RA in different levels, in addition to the SVC and IVC. All right. And this is an example of a shunt run. So the superior vena cava is measured at 55%. That's the oxygen saturation and the superior vena cava. And the inferior vena cava at 75%. So it's 55-75. But notice in the right atrium, there's a sudden increase in the oxygen saturation. Here it's 70% in the high RA, mid RA it's 79, low RA is 83%. So the oxygen saturation has jumped. It shouldn't, and that oxygen saturation carries on to the pulmonary artery there at 80% and to the RV. So there is a step up in the oxygen saturation at the level of the right atrium. And this suggests the presence of an ASD. Okay. Now, in real practice, most cases would be diagnosed already with echo or a cardiac MRI, non-invasively, but once in a while we'll have a case like that. This is a shunt run that I did in my lab. This is a case that I did. And usually when we're doing the samples, the nurse will write it on a whiteboard so we can all see it there and see what's going on instead of trying to remember it in our minds. Okay. So in this case, notice that the IVC oxygen saturation is 69%. Innominate vein, which is above the IVC, is almost 70%. The high SVC was 71%. However, in the low SVC, there is a sudden increase in the oxygen saturation. It went from 71% to 84%. And that transmits to the right atrium, right ventricle, pulmonary artery. There is a step up in the oxygen. So there is somewhere that the blood is coming back to the right circulation that's oxygenated. Anyone want to take a guess what pathology can cause this jump in the oxygen saturation at the level of the SVC? You can write it in the chat. I'll leave it up for, I'll give you guys 15 seconds to think about it, and I'll give you what the answer is. Anomalous PV drainage, anomalous. So no, not sinus venosus is a very good thought, but sinus venosus is still within the right atrium, although it happens higher. This is a case of partial anomalous. So I think Dr. Bahir got it right. Anomalous PV drainage, and Dr. Larkley as well. So there is a partial anomalous pulmonary venous return. Okay, it has to be partial because the pulmonary veins return usually to the left atrium. All right. If there was complete anomalous return, then there would be no blood going back to the left atrium. But one or two of the pulmonary veins, instead of going to the left atrium, actually go into the SVC, and that causes oxygenated blood to return back to the right circulation and causes this step up in the oxygen saturation. Good. All right. So now it's going to get really confusing. Okay. So now we're going to do QPQS. So QPQS is a measurement of how much what's the flow in the lung circulation or pulmonary circulation compared to the systemic circulation. Okay, so normally the pulmonary flow is same as the systemic flow. The cardiac output in the pulmonary circulation is the same as the systemic circulation. All right, and that's why when the Fick equation, we took the pulmonary artery sample instead of a mixed venous sample. But when you have a shunt, there is more blood going through the pulmonary circulation compared to the systemic circulation. So QPQS is a measurement, the ratio of pulmonary flow to systemic flow. Okay, depending on what you read, anything more than 1.5 to 2 to 1 is considered a significant shunt. Okay, so if you have a patient with the VSD that looks restrictive, but you're not sure, on echo we do a QPQS. We can demonstrate whether or not the shunting is actually severe or not, for example. Okay. So how do we calculate the QPQS? So remember when I talked about the Fick equation, I said that cardiac output equals the VO2 divided by the hemoglobin multiplied by 1.34, which is a constant, multiplied by the difference in the oxygen saturation. Now we're dealing now with two different circulations, the lung circulation and the systemic circulation. So for the lung circulation, the pulmonary venous O2 sat is where the high oxygen content is, because that's what drains the pulmonary what drains the blood through the lungs. So pulmonary venous O2 sat will have high oxygen saturation minus the PaO2 sat, the blood going into the lungs, which has the lower oxygen saturation. So this would help us calculate pulmonary blood flow. Okay. QS, the systemic circulation, is the VO2 divided by hemoglobin multiplied by 1.34 multiplied by the systemic saturation, because that's what's leaving going into the systemic circulation, minus the mixed venous oxygen saturation, which is the venous return to the heart. Okay, from the systemic circulation, and the mixed venous oxygen saturation, it will be difficult to measure. So there's some calculations for that, and we'll get into that. But to simplify, QP divided by QS equals, if we put these on together, the VO2 divided by the hemoglobin by 1.34 تحصيل حاصل هينحوا بعضهم لأن هذوما ال PVO2 sat minus PO2 sat في المقام حيولوا بسط وهكذا. ففي المعادلة SaO2 saturation, systemic O2 saturation minus the mixed venous oxygen saturation divided by pulmonary venous oxygen saturation minus the pulmonary arterial oxygen saturation. Okay, so you need all four of these to be able to calculate the QP/QS. Okay, so again, this is هذا المعادلة. For where do we get these? The systemic oxygen saturation is measured directly. You can take an ABG, a O2 sat, or if you're doing a left and right heart cath, you can take a blood sample directly. It can be measured directly, not difficult. Okay, we'll get to the MVO2 sat on the next slide. The PVO2 sat, the pulmonary venous O2 sat, should be the same as the systemic oxygen saturation, assuming there is no right to left circulation. The lungs oxygenate the blood. They go into the pulmonary veins, return to the left atrium, goes to the left ventricle. So they should be the same as the systemic. Or if you're worried about a left to right, right to left shunt, then just use 98%. Okay. So far, so good, easy. The PaO2 sat is the pulmonary arterial saturation. We go in there with the catheter, we take a blood sample, we measure it directly. So the last thing we're left with is the mixed venous O2 sat. So the mixed venous O2 sat is not the PaO2 sat when there's a shunt. They're different. Okay. So what is the mixed venous O2 sat? Where does this blood come from? So the blood returns from the SVC, the IVC, and the coronary sinus. Okay. And they have different levels of deoxygenation. Coronary sinus is the venous drainage of the heart, and the heart is a very efficient oxygen extraction organ. It needs a lot of oxygen, so the blood returning into the coronary sinus has a very low oxygen saturation. So it's the lowest of the three. The highest of the three is the IVC, meaning the oxygen concentration from the IVC should be higher than the SVC and the coronary sinus. Why is that? Well, there's an organ that's drained by the IVC that gets 20% of the cardiac output, not because it needs that oxygen, but because it needs to filtrate the blood, which is the kidneys. So the kidneys get the blood through, filtrates it, and sends it back using the amount of oxygen it needs, and which is usually not a high percentage. And then the SVC drains the arms, but also drains the brain, which is also a oxygen-heavy dependent organ. So that means that the blood return to the right atrium from the SVC and the IVC and the coronary sinus gets mixed there with different levels. And the problem is we don't know which point of the right atrium should we measure in to get the mixed venous. Furthermore, if the shunt isn't the right atrial level, that's going to confuse the measurements. So there is a calculation to measure the mixed venous. You take a sample of the oxygen from the SVC, a sample of oxygen from the IVC, and this is called the Flan formula, where the mixed venous oxygen saturation is 3 times the SVC plus the IVC divided by 4. And the idea is that, the SVC is kind of in the middle, so it accounts for the coronary sinus that would be lower. And this has been validated and is a good calculation for the mixed venous O2 sat. So I've shown you what numbers you need to calculate the QPQS. So let's go back to this example, and you're asked the question how to calculate the QPQS. So QPQS, this is the هذا المعادلة اللي طلعنا بيها. Systemic oxygen saturation minus mixed venous oxygen saturation. So the mixed venous oxygen saturation is 3 times the SVC plus the IVC divided by 4. 3 times the SVC. The SVC here is 55% plus 75% divided by 4. درت الحسبة امبارح طلعت لي 60. Okay. Don't need to pull the calculators. So QPQS equals 98, which is the systemic circulation here, aorta, 98%, minus the mixed venous, which is 60, divided by the PVO2 sat. Now, here it's been given to you. Pulmonary vein is 99%, so then we use 99%. And the pulmonary artery measurement was 80. So 99 minus 80, okay? Which equals 38 divided by 19. 38 divided by 19 is 2-to-1, which means that for every liter of blood going through the systemic circulation, 2 liters of blood has to go through the pulmonary circulation. So this is a shunt of 2-to-1, which is a very significant shunt. Now, this is a very good measurement of the severity of shunts, but other things to look at would be right ventricular dilatation, symptoms, etc. Okay, so that's the shunts on the right heart cath. I'm going to talk about valvular disease next. So majority of valvular disease now are diagnosed non-invasively, but some cases you might need hemodynamic assessment. So I'll give you a clinical scenario. 68-year-old gentleman with shortness of breath on exertion has a long-standing NYHA class 2. On exam, there's an ejection systolic murmur concerning for aortic stenosis. He's moderately obese. TTE shows moderately to severe aortic stenosis. The echo guys, when they report, they're not sure if it's severe or moderate. They'll give you a report which, they pass the buck to you, and you have to make a decision. But the calculated aortic valve area is 1.1 with the mean gradient of 30 millimeter mercury. But they do tell you that the image quality is poor, which means that they're not 100% sure how severe the aortic stenosis is. So why is this patient short of breath? Is he short of breath because of the severe aortic stenosis, or is it because of the obesity? Is there tests that could help us? You could do a TEE, for example, but that's also invasive. So it's important. Now we're talking about valvular disease. Usually we do a left and a right heart cath at the same time. So it's important to know what the Wigger diagram looks like. So normal Wigger diagram has 3 waveforms. You have the left ventricle, the left atrium, and the aorta. Okay. So the left ventricle, there's an atrial notch which corresponds to the atrial contraction, and then there is systole goes up, isovolemic contraction up until the aortic valve opens, and then you get this waveform, and then the pressure starts dropping once the blood is empty, and the aortic valve closes, and you have isovolemic relaxation up until the mitral valve opens, and then you start having diastole. Okay, so diastole is the waveform is kind of flat after an early filling period, and then the A wave. Notice here, if you superimpose the aortic waveform on top of the left ventricular waveform, there should not be much of a difference or gradient between the waveforms here, between the left between the left ventricle and the aortic pressure. Same here during diastole. If you superimpose the left atrial pressure, we talked about this already in the when we reviewed the wedge pressure. During diastole, there shouldn't be a much gradient between the left atrium and the left ventricle beyond the early filling phase. Okay. In aortic stenosis, because there's a severe narrowing, now the pressure inside the left ventricle has to go much higher to be able to get blood into the circulation. So instead of the left ventricular and the aortic pressure being close to each other, there's a big gradient. There's this area under the curve between the left ventricle and the aorta. All right. And this is what it would look like on the cath. Now, this is not done perfectly because this is a pullback, meaning they had a catheter inside the left ventricle and we pulled it back, and then the 2 waveforms were imposed on each other. If you really need accurate measurements, you need simultaneous pressures, and that's a whole other lecture about how to get simultaneous pressures. But notice here that there's a big gradient between the left ventricle and the left and the aorta, especially at systole there. And that dark area under the curve, the software can calculate that and give you the mean gradient. In this case, the mean gradient is 63, so definitely severe. All right, this is another pullback, kind of a diagnosis. What is happening here? So there's a pressure inside the left ventricle. The catheter is in the distal part of the left ventricle, and then on pulling back, the pressure waveform changes. And this is the second page, ongoing pulling, and then you get back into the aorta. So there's definitely a gradient between the left ventricle and the aorta. But how do we explain that's what's happening in the middle? Is this severe aortic stenosis? I'll give you 15 seconds for people to type in the chat if they think they know what's going on here. Now, this is a real case that I, my measurements here, not the cath lab. So someone said mixed disease. Good thought. Aortic stenosis, severe AS. So there is a severe gradient, but the gradient is not between the left ventricle. Yeah, Dr. Bahilil, dynamic obstruction. Excellent. So the gradient is not between the left ventricle and the aorta. It's between the distal left ventricle and the proximal left ventricle. So the obstruction is subaortic. This is hypertrophic obstructive cardiomyopathy. So we're still in the left ventricle, but there's a sudden pressure gradient there. You also have this spike and dome pattern that is consistent with dynamic obstruction, LVOT obstruction. And then when we go into the aorta, here there's not much of a gradient. The systolic pressure in the ventricle and the systolic pressure in the aorta is the same. So there's no aortic stenosis. It's all in the LVOT, and you got that spike and dome pattern. In mitral stenosis, the pressure is now between the left ventricle and the left atrium because the mitral valve is tight. So now you'll get a diastolic gradient. All right, and that area can be measured and reported as a gradient. So this is what a very severe mitral stenosis would look like. This is the left. So to do this, first of all, we need to do a right and left heart cath. We'll have a catheter in the left ventricle, and then we have a swan balloon inflated and wedged in to get the left atrial pressure. Notice here, remember that I talked about the swan pressure, because it's a left atrium, gets delayed. The technician has moved this along so that the left atrial pressure peak will cut will correspond with the isovolume contraction to adjust for that time difference. Notice here during diastole, there is a big area under the curve between the left atrial diastolic pressure and the left ventricular diastolic pressure. Also, despite having a very big A wave, we don't see an A wave transmitted over in the left ventricular pressure. So this is a huge gradient across the mitral valve. All right. And there's also a huge V wave as well because the pressure with the volume returning to the left atrium is high. Okay. So I can tell you what the aortic gradient is, but can we calculate what the aortic area is? So there is a formula called the Gorlin formula. If we think about it, the flow across the valve, how much blood is going across the valve, is equal to the valve area, how big the valve is, and the velocity of the blood going through. السرعة مضروبة في المساحة. هعطيك how much الكمية الدم اللي is going across the valve. Okay. So طرفين في الوسطين, the valve area equals the flow across the valve divided by velocity. Okay. And the velocity عملية حسابية 44.5 multiplied by a square mean valve gradient. الجذر بتاع mean valve gradient. And the mean valve gradient we measure directly. Okay. So how do we calculate the flow across the valve? So the flow across the valve equals the cardiac output divided by heart rate, because we want to know the flow across each cardiac cycle, not because we're measuring the mean valve area or gradient in each cardiac cycle. So it's the cardiac output divided by the heart rate. But remember, the flow only happens during systole and aortic stenosis. So even though if you divided the cardiac output by heart rate, you still need to calculate or adjust for the systolic ejection period, the duration of systole. Okay. And with that information, we get the aortic valve area. We can calculate it by cardiac output divided by a systolic ejection period multiplied by heart rate. That will give you the flow across the aortic valve, multiplied 44.3 square mitral valve gradient. That will give you the velocity. I know this is very quick and it's a complex calculation, but let's just go over the things you need to measure. Cardiac output. We know how to measure cardiac output. You use the Fick equation or you use the thermodilution. All right. The heart rate, we know what the heart rate is, and the systolic ejection period, the software will calculate that. And we're able to measure the mean valvular gradient because that's what we're doing. And if you plug that in, you can be able to get the you can get the aortic valve area calculated. And mitral stenosis, same thing. Flow across the valve equals valve area multiplied by velocity. Same calculation. And now for the cardiac output, the flow happens during diastole. So it's the heart rate multiplied by diastolic filling pressure. So cardiac output divided by heart rate multiplied by diastolic filling pressure. But there is a correction factor of 0.85. And that's what that equals. Cardiac output divided by DFP multiplied by heart rate by 0.85 multiplied by 44.3, the square root of mitral valve gradient. So this is a case that we have here in the software. Will actually do that for you. You don't have to sit down with a piece of paper. Just make sure that you get good measurements, and it'll plug it in. So this is a simultaneous left atrium and left ventricular pressure. Okay, there is a clear area under the curve, a diastolic gradient. Look here, the heart rate's in there. Cardiac output is in there because you've already calculated it. This is the mean gradient of 9.21. So getting close, but not as a severe measurement. However, the diastolic filling period, the software will calculate it for you. And with this information, it gives you an valve area of 0.83, which is more on the severe side, which, if the patient has good symptoms and that's what you're getting calculated, then maybe an intervention is warranted. Now, these measurements are usually you can reach the diagnosis of severe mitral stenosis or severe aortic stenosis by non-invasive measurements. So I see Dr. Slake has commented that it's if you get good imaging and history, it's kind of might be of historical interest. However, we still see those cases where we're not 100% sure, but we think they have the disease, and we're going to be sending them for surgery. The surgeon will need a coronary angiogram anyways. So by adding a right heart cath, we get more information to confirm that we're doing the right thing, or if we're not sure, the other way around. So that's still some utility there. And there are still cases where we're not 100% sure. Not common, but we do see them from time to time. How are we doing for time? So I'm getting to the last part, constrictive pericarditis. Because I showed this, if you were at the Libyan Cardiovascular Society meeting in the Jeopardy, I had this as a final Jeopardy round. Okay, so this is a patient who has heavy calcification in the pericardium. So there is concern that this patient has constrictive pericarditis. All right. How does hemodynamics help you? This is the other image showing the calcified pericardium. So constrictive pericarditis is a very interesting, unique hemodynamics. All right, it's think about it as the heart is a balloon inside a vase, inside a big rock. Okay, during early diastole, it fills up rapidly and then suddenly can't fill anymore because it hits the wall of the vase. Okay. So things that you will see, these are the findings that you will see with constrictive pericarditis, and I'll go through them very quickly. So the first thing is the square root sign. You'll have a big decline in the pressure, on an exam, you'll see a rapid Y descent, and then it comes up quickly again, and then stabilizes. There's no more room to take, the pressure goes up, so you have the square root sign, so it'll be stable, all right? Same in the right ventricle and the left ventricle. Also, the right ventricle and diastolic pressure is elevated. However, because this is not a high filling pressure in the lung circulation itself, you don't get an elevated pulmonary arterial systolic pressure. Should not be more than 55 millimeter mercury. If it's 60 or 70, you have to think about restriction instead of constriction. Okay. There's also equalization of pressure, meaning that during diastole, the RV and the left ventricle diastolic pressure are very close to each other, the less than 5 millimeter mercury difference. All right, so those are all features of that early filling, and then pressures become stable throughout or similar throughout in the vase. Okay, a more sensitive and important finding is ventricular interdependence. Now, all the chambers of the heart are inside the pericardium except for the left atrium. So the thick rock that we see from the pericarditis isolates the heart from the intrathoracic pressures, except for the left atrium. So when you breathe in, there is a negative pressure on the left atrium, reducing the left atrial filling and reducing the blood return to the left ventricle. And that space gets taken up by the right ventricle, so you get an increase in right ventricular pressure. Usually, right ventricular and left ventricular pressure go up together during systole, during inspiration and respiration. But in constriction, that is reversed. So what you need to do is measure the right ventricular and left ventricular pressure simultaneously. And with respiration, you'll see here that the left ventricular pressure goes up and then down. However, the right ventricular pressure instead goes up when the left ventricular pressure goes down. And that is consistent with ventricular interdependence and is a very sensitive sign for constrictive pericarditis. All right. I'm sure I confused you. It's a very thick subject. It's hard to cram in 1 hour. There's a lot of extra reading you probably should do around this. But invasive hemodynamic assessment is clinically useful in various clinical scenarios. More importantly, even though this is all some of these things might be considered historic, understanding hemodynamic assessment improves our understanding of cardiovascular physiology and pathology. And there's lots of resources available to read and expand your understanding of hemodynamics. And I will stop there for questions and discussion.
Okay, thank you very much, Dr. Elbarouni's excellent presentation. Well done, well summarized. It's a huge topic, interventional cardiology. And this is one of the skills that everybody has to learn to be actually mastering that, because we still definitely need right heart cath from time to time for certain conditions. As you mentioned, Basem, it's not history yet, so we still need to use it and need to master it, need to learn the pros and cons of this. There are lots of information and mathematical equations that you need to learn, but once you master them and you do them a few times, that'll be really easy. We have softwares to help, so don't worry, you don't need to know all those calculations, and the team will help. It usually needs teamwork. So from here, I'll open it for the expert panel to say a couple of wisdom words. So Dr. Basem Elbarouni and Dr. Mohammed Al-Ayyan. I'll start with you, Dr. Elbarouni. If you have any quick comments, then we'll move on to the questions after that.
شكرا دكتور باسم. It was very excellent والله بارك الله فيك. I learned a lot. حاولت تعطي summary لموضوع complex و complicated. الكومنت الوحيد اللي بنقولها ان احنا we are underusing الرايت هارت catheterization في ليبيا للاسف الشديد، مش لانها هي historical part ونحن تحسنا في موضوع الفالف assessment وغيرها، لكن a lot of cases تاع pulmonary hypertension they are circulating والdiagnosis depending only على الايكو، رغم ان عارفين المآخذ الdiagnosis pulmonary hypertension cases with echo only، لكن الليكتشر حقيقه it is very nice, concise, to the point. You covered all the points and I learned a lot. بارك الله فيك.
ما فيش مشكلة.
شكرا دكتور أسامة. دكتور محمد العيان, if you have a couple of comments.
Sure. Assalamu alaikum. Thank you very much, Basem. You did a fantastic job to summarize this very broad topic. It's complex. Just have a few comments about the technicality of the right heart cath. So as we know, we have three approaches. We can go from the neck, or we can go from the groin, or we can go from the arm. I usually prefer to go from the arm, okay, especially if it's just diagnostic. If we're gonna leave the catheter, I usually go from the neck. But if I'm gonna do just diagnostic, I go from the arm. It's more safe, okay. It's you avoid the complication from going from the neck. It's more comfortable to the patient. So usually I go through the antecubital. I use the ultrasound. Okay, I try to go through the basilic vein. Basilic vein is more medial. When you go through the basilic vein, it's usually easy to get to the subclavian. When you go to the cephalic vein, which is more lateral, usually there's a bend between the end of the cephalic vein and the subclavian, and sometimes it's hard to negotiate. So that's one thing. The other thing, we need to make sure about that the transducer is on the level of the heart, because sometimes I see that the transducer is up and down, and it can give error in measurements. The other thing which I would like to mention, as Basem said, the balloon should be always up when you are advancing across the valve. However, when you are pulling back through the valve, the balloon should be down, so you avoid causing any damage to the valve. And when you are inside the chamber, the balloon should always be up, so you avoid causing any irritation to the ventricle or to the atrium and causing arrhythmias. Another thing which we need to know, when we measure the pressure, we should have column of water, not blood. So when we measure the pressure, we need to flush. We have column of water rather than blood, and that's give you more accurate measurements. And when you go to the wedge pressure, okay, you need to discard some blood if you wanted to check the oxygen saturation, the wedge sat. You need to discard at least 20 cc of blood, because I see sometimes people, they discard just a little, like 5 cc, and this sometimes can give you error in measurements. So you need to discard enough blood, which is the column of blood from the across the whole circulation. And another thing, when you measure the pressure, you need to take the pressure at the end of expiration. And the reason for that, when you measure the pressure at the end of expiration, that's when the intrathoracic pressure is almost zero. So that's another thing which I think it's important to remember. I know it's a very broad topic, but those are some technical points that I would like everybody to know.
Perfect. Thank you, Dr. Muhammad Layan. Excellent points, and Dr. Sam Bahrain also excellent points. I would encourage people to know all the techniques, to be honest with you, during training. So definitely try to learn the IJ, the antecubital, and try to use the femoral approaches, all of them. You have to master them, and then you pick a certain approach that's easy and has less complications and risks. So definitely all of them are doable, because sometimes you have technical difficulties to get access. For example, if you have neck issues, or if you have femoral problems, or you have other issues that you need to know to go to the other route to get the access. So I will open it to questions. I have Dr. Mahyar and a question, inshallah. You can okay, Dr. Mahyar Hamadani, تفضل, yeah.
Assalamu alaikum. Thank you all. Basem, that's a great job. I mean, I would probably refrain from doing it the way how you did, and I'll divide this into 4 lectures, and I'll probably demand that. But that's really a great, quick, if you will. I mean, that's why some of the comment in the beginning, they said, you know, can you please explain more? And I can, you know, sympathize with those who couldn't not comprehend everything at once. No, I mean, that's really great. Just 2 things that I want to mention, you know, because you mentioned about the FIC method and determined dilution. And another thing that will restrict the FIC method, if there is a significant anemia, you try to avoid using the FIC method in those cases. The other thing that, you know, many times that when we wedge, and I agree about the comment of trying to be safe in wedging, when you try to wedge and you're not sure, sometimes there is sometimes difficult. Am I wedging? I'm not wedging. The best way to do, as you think that you're pushing that balloon against till the end of the pulmonary artery that you can, and then probably at that time when you are at that point, you can really take saturation. If your saturation is 92, 94, 95, 96, then most likely you are in the accurate wedge position, so you can continue wedging. If it is really coming like in the 70s, 78, 79, or 72, so you know that you're not wedging, and there's a lot of mixed blood from the pulmonary artery over there. And so you have to really repeat your wedging so you get an accurate wedge. The other thing that worth to mention is that as you wedge and you got the right wedging, and when you're doing your left ventricular end-diastolic pressure, that difference between the left ventricular end-diastolic pressure and the wedge pressure should be 5 or less. If it is more than 5, then there is a mistake in the wedge, and you probably have to repeat that again. You know, ironically, sometimes coincidentally, you get your catheter. Especially now we have the TIG catheters for the radials. You get them through the mitral valve into the left atrium. Please don't pull quickly. Just take that pressure and use it as your best left atrial pressure, and then you can really correct your catheter. And again, it's a great topic, and thank you for the presentation.
Thank you very much. Yeah.
Mahyar, I'm not sure if you do this or not. One of my colleagues does this, and he's pretty confident doing it. If you're not sure that you're wedged, you can actually inject contrast through the tip of the swan, and you can see if there's any blood leaking back or if it's all going down to the pulmonary artery. And that would give you a good clear that you're wedged. Problem with that is now that you have to flush the whole system again and clear it from contrast to get a good waveform. And if there's severe pulmonary hypertension, I probably would avoid doing that.
Yeah, I agree with you, Basem. I think you just give yourself time and move up and down. So if you can't wedge from certain area in the right side, move to the lower lobe of the lung, or move to the right pulmonary if you're on the left, and vice versa. You'll find the wedge easily if you take time and just don't stick to one point. Don't stick to one area, then start pushing and pushing. No, just move. You can't find it there, move to the other area, and you'll be able to. Sometimes if it's really difficult, then you change the catheter. That's another thing that might help if it take you time and catheter becomes soft. So just use cold saline or change it. So I have Dr. Adil Dayoub. You can unmute yourself, Dr. Adil.
Okay. السلام عليكم.
سلام الله.
محاضرة شيقة جدا وممتازة جدا باسم بارك الله فيك. I think this is the topic that was very, very, very complicated for me for the Royal College exam. And to the يعني السؤال تبع هذه الويف فورم تبع CVB والويدج, that was my Royal College exam question on the written. Question مهم بالنسبة لجماعة الجراحة تقريبا أكثر. We do right heart cath and it's 1 Gans in every pretty much 90% of our patient. Unfortunately, we're still lagging in terms of monitoring patient. Our center still does swan and 90% of the patient goes for open heart surgery. My 2 concerns or my 2 words of cautions when you do right heart cath, and somebody comes with a very bradycardia or left bundle branch. I've had 3 or 4 patients who had asystole. As soon as they pass the catheter down, they try to float the catheter, arrested. So this is a word of caution. Do you have a criteria to which you don't do right heart cath, or you get some precautions? So I've had few patients arrested on me on placing a swan. Second, when it comes to those people you operate on with pulmonary hypertension, especially the moderate to severe, sometimes you have some people almost systemic pulmonary hypertension. We send those for the right heart cath to try to find out if there is an element of reversibility of their pulmonary hypertension. The question is, could you elaborate on what to do when you're testing for reversibility of pulmonary hypertension? If you measure somebody's pulmonary vascular resistance is 6 units or 5 units, or do you just tell me this, or do you provide me more additional information to tell me this is reversible? If you fix the left side, if you replace the mitral valve for the mitral stenosis, this is going to improve, or this is a fixed pulmonary hypertension, because it means a lot to the outcome of the patient. Thank you, Basem.
Okay, so Jamil, so will is your conjugation. So if you have a left bundle branch block, and there's a good indication for the right heart cath. If the indication is kind of soft, I'll probably cancel it. If there's a good indication you really need it, then the first thing to do is I would definitely not go femoral, because you don't want to try and play around. Femoral is a bit more challenging to get the catheter in. I'd go either IJ or subclavian or antecubital, because it'll float quicker. And I wouldn't take a right ventricular pressure. I would just go quickly across the right ventricle, hope not to do a PVC, have the transcutaneous pads on. And then on the way back, I wouldn't measure the right ventricular pressure either. I just come back straight to the right atrium, because that's the right ventricle is where the ectopics might happen by the catheter tip and cause the trigger a complete heart block. Turn to the second question. It all comes down to transpulmonary gradient. All right. If your transpulmonary, if you have a patient with a low wedge pressure and a high pulmonary systemic circulation, and your transpulmonary gradient is very high, then most of that is fixed. All right. The PVR is basically built into trying to calculate how much of that is reversible. If you have like the example here, if your transpulmonary gradient is low, or less than 20, then there's a bit, and your RV, like if your wedge pressure is 25 and your transpulmonary gradient is 17, that's still high, but a lot of that should be reversible. That's where the pulmonary vascular resistance comes in. Now, that's different than trying to test to see if there is a response to nitric oxide that used to be used to assess whether or not calcium channel blockers would be useful in pulmonary arterial hypertension. But basically, the hemodynamics, if you have a high transpulmonary gradient, a high pulmonary vascular resistance makes, and the wedge pressure is not that high, then it's unlikely that it's going to be reversible. But if you have a very high wedge pressure, you might have a significant improvement if you manage to get the patient through surgery.
Yeah, excellent, Basem. I agree with those comments. There's a question about pulmonary artery catheterization for pulmonary hypertension and responsiveness to therapy. Dr. Sam Haley, do you have any comments about that? If you give patients treatment for primary pulmonary hypertension, especially, for example, CCPs, calcium channel blockers, responsiveness to that, and role of a right heart cath.
وشكرا. السؤال هذا مهم جدا، بالاخص احنا we have cases تاع pulmonary hypertension. الحقيقه we don't do a vasoreactivity test في ليبيا لانه we don't have the substances اللي هي that can be used for vasoreactivity test اللي هو either IV ibuprostanol ولا inhaled iloprost ولا nitrous inhaled nitrous oxide. الحقيقه many people in Libya they use oxygen for the reversibility test, which is very outdated and out of the guidelines. زمان كنا نستعمل في الادينوسين، تعطي الادينوسين انفيوجن، لكن to be honest توا حتى في الجايد لاينز الاخيره اليوروبيان جايد لاينز في 2022 it is كان في الكلاسيفيكيشن الاول كان في الجايد لاينز الاولى كلاس 2A، توا it is not used anymore. And for vasoreactivity test many people في ليبيا they use oxygen which is not the ideal. في بعض الناس قالوا لي استعملوا في النيتروس اوكسايد، ممكن في بعض الدول الثانيه، لكن في الجايد لاينز ممكن الانسر اللي جاء للدكتور عادل ديوب على حسب البلمونري فاسكولار ريزيستنس، اذا كان more than 5 Wood's unit then it's irreversible. I think there is no rule at surgery. إذا كان less than 3 yes، إذا كان between 3 and 5 then you give the patient a chance تعطي vasodilator substance either endothelial receptor antagonist ولا phosphodiesterase inhibitors and you give them 4 months and then re-evaluate them. إذا كان الpulmonary vascular resistance drop then you can operate them, otherwise leave the patient.
Thank you, Dr. Bhale. Excellent answer. I would add to the reversibility is the history also. So, for example, if you're operating on VSD or ASD, and you know this patient has pulmonary hypertension, that's Eisenmenger syndrome. So that's irreversible. So don't try to do that.
The only indication of reversibility ولا vasoreactive test كان the same language اللي هم جماعة الديوباثيك اللي هم الجروب 1 pulmonary hypertension اللي هم يجوا الهيريديتري او جماعة الدراج انديوس او توكسيك انديوس. هذوما الثري كاتيجوريز اللي هم يستعملوا الفازورياكتيفيتي اللي هم they might benefit from the calcium channel blocker hide. Otherwise there is no indication. The patient عنده scleroderma, you send them for right heart cath. No one will do a vasoreactivity test باش تعطيه calcium channel blocker. Direct you send them for combination therapy. endothelin antagonist زائد واحد من الفايف
Perfect. Yeah, thanks, Dr. Osama. Yeah, you may just bring them back to do another right heart cath and compare. That's maybe just to help to see if there's any change. Dr. Al-Mahdi Al-Khammas, nice to have you with us, Dr. Al-Khammas. You have the floor. You can say your comments, and if you have any questions, unmute yourself, please.
السلام عليكم. مسموع الصوت كويس يا دكتور؟
مسموع كويس دكتور مهدي، اهلا بك.
اولا انا سعيد جدا الحقيقه. I'm really very happy and delighted, and I like to commend your efforts. These are great lectures. Dr. Elbarouni, you delivered an outstanding lecture. I'm really happy to be part of it. Of course, probably 2/3 of it I didn't understand very well, but there is a little area. Yeah, but there is a little area where that's where my question is coming from. With the liver patients, dealing with the cirrhotic patients, about 3 to 5% of them, they develop pulmonary hypertension, what we call it portopulmonary hypertension. And we do use mean pulmonary arterial pressure over 25 to about 26. That's our cutoff for diagnosing it, and the BVR greater than 3 Wood units. And And we started feeling uncomfortable if it's over 28 to about 35. But if it's over 35, we think it's contraindicated to do a liver transplant. And just anecdotal, I feel either the period of existence of the portopulmonary hypertension or the severity, I'm confused between them, that at one point you reach where some structural changes happens, and even if you treat with vasodilators or prostaglandins or nitric oxide, whatever you like, or it's available in your protocol, it become really insignificant, and it's still poor prognosis after the liver transplant. Do you have any comments or ideas when you think we should not even think of putting the patient on the waiting list, or if we want to treat them and they respond a little bit, for how long should we treat them before we feel comfortable in doing the liver transplant? I really appreciate your comments, but outstanding activity of the young people, it just thrills me. I'm just so happy to see you guys.
Thank you very much. We're really happy to have you with us, and it's really excellent comments. We learn from you, and we hope we see you again. And it's important that we have all the support from each other. It's a work it's a teamwork. It's team effort.
Definitely.
Okay, so Dr. Rida Al-Oakley, nice to have you as well. Please, you have the floor.
دكتور الخماس اسال سؤال ما جاوبناش عليه.
حنعطيه للدكتور محمد العيان ان شاء الله.
بارك الله فيك.
انت طيب ان شاء الله. I know that. لكن بس بيشتغل الدكتور رضا العقلي يستنى ان شاء الله. تفضل دكتور رضا. Unmute yourself دكتور رضا. If you can unmute yourself, yeah.
Okay, تمام. السلام عليكم ورحمة الله. Another elegant session. Thank you, Abdul Ghani. Thank you, Basem, really for a super presentation. And I think I can understand how probably Dr. Adil was concerned about before his last debate because of the elegance of the speaker and the fantastic. I really learned a lot about right heart catheter and endomyocardial biopsy only when I became a fellow of heart transplant many years ago in Manchester. And I recommend anyone who's interested to know more after today's talk, I think, is to visit one of the cardiac transplant centers in the post-transplantation clinics, where you'll be able to see maybe up to 15 right heart catheters in one session, including endomyocardial biopsies. Very impressive, very fast, and very elegant way of doing it. Really, the question I have is somewhere maybe is related, but maybe somewhat distant. And I think Adil have alluded to it, that the use of right heart catheter in cardiac surgeries has been abandoned by many centers. I don't know how far maybe you guys working in the West now will have access to the latest regarding the non-invasive methods of assessing cardiac output. Maybe you can please just advise us or tell us more, I have not been to many international meetings since Corona or even before Corona. So it'd be nice to know and keep us updated. Maybe Adil also can catch up with the latest about non-invasive methods of assessing cardiac functions. Thank you, Basem.
Thank you very much. Excellent comments, and definitely will answer this question, non-invasive. So, Dr. Al-Ayyan, if you can hear us, I think you heard the question of Dr. Mahdi Al-Khammas about the
I heard the question, but I don't know if there's any specific numbers. So I don't know if I'm not sure about the answer, to be honest.
هو سؤال جميل, لكن if I'm going to be honest, I don't manage those patients. I don't see them often.
Me too. I don't know.
And most of the pulmonary hypertension, even though we do the right heart cath and give the diagnosis, the ongoing management is usually by a respirologist, lung doctor who specializes in pulmonary hypertension. So I would, I think it's a really good question, but I have no idea. It's I wish I had a better answer for. We had a better answer for you. بالنسبة للسؤال أنت دكتور العقلي, non-invasive hemodynamic assessment is an interesting field. It's not mainstream. في أجهزة جديدة NICAS إن تحط electrodes على patient will give you a cardiac output and SVR and at least it'll give you a cardiac output. And one of my colleagues is doing a research study. So every STEMI that comes into the cath lab, they'll measure the use the device before and after the procedure and monitor their outcomes to see if it can help predict the patient outcomes and all that. But that's still in the research trial. So I don't think it's mainstream, at least that I'm not aware of, that the non-invasive methods are being used. I don't know what our cardiac surgery practice is, but in general, the routine use of swans in the ICUs and intensive cares has been abandoned a while back because one study, a big randomized trial didn't show any benefit and actually showed increased mortality. The problem is it's a diagnostic test. So if you're using it in the right context where you're not sure about what the diagnosis is, or it helps you, or you know what to do with the numbers, then it makes sense. But I'm not sure that there is a role for routine use in most places. Dr. Oakley commented on the role of right heart cath post biopsy, post heart transplant. So patients who are post heart transplant need frequent routine myocardial biopsies done. So and early in the transplant, it happens on a weekly basis and then on a monthly basis and then once a year for a while to monitor for early signs of cellular rejection, because it's important for the heart failure docs to pick that up early to be able to adjust the immunosuppression modality. So the procedure is done somewhat similar to right heart cath, but it involves also going with the special device, a biotome, to take a few samples. And usually what I do is I'll do a right heart cath at the same setting, take the full samples, the pressures, and then I'll do the biopsy part. But it's more for the biopsy part, not just the right heart cath. Usually the right heart cath is to reassure the heart failure doc that everything's looking good, the filling pressures are normal. But it's more for the biopsies where it's important. So yeah, you've got tons of heart transplant patients get tons of biopsies done.
Yeah, thank you, Basem. I definitely agree with those comments. I have done many right side catheterization and biopsies when I did my training, and it's very interesting, fascinating, as Dr. Oakley mentioned. You will see lots of number one, you have a chance to learn and do it, and you master it. Number two, you see the even the weird and complicated cases and how to manage and prevent complications, and also when it's difficult, how to manage to do the cast. So when it's straightforward, it won't take you long. It will be very straightforward and easy to be done when you do lots of cases. So volume is important. So Dr. Al-Oakley, you have another question. Dr. Rida Al-Oakley, you have your hand up. Please go ahead.
Assalamu alaikum. No, Basem made me think of another question, really, which I was reading yesterday about the Maryland xenotransplantation case in the New England Journal of Medicine, and the first biopsy done was 30 days after transplantation. And I thought that you should be doing it earlier, week 1, 2, 3, and 4, until all is under control. Although they're probably not suspecting cellular rejection, but they have not. The first biopsy was done after transplantation was 30 days, and the last two, one was in, I think, 50 days, and the one in postmortem when the patient died at 60s. Can you explain why was the biopsy not done before 30 days? Thank you.
I wish I knew. I did not know that, and I agree. It's a bit unusual because the biopsies are done very frequently early on. But I don't manage those patients. I just get to do their biopsies. So I probably, if we had a transplant specialist, a heart failure specialist, might be able to answer that a bit more. But I'm pretty sure they get biopsies done earlier than that.
Yeah, there's protocol, Dr. Oakley. So it's done like usually within first week, sometimes 5 days, and then 2 weeks, 3 weeks, 1 month. Then you move. So that, and then you see, depends on the result of the biopsy. If no rejection, you move it to 3 months, and then 6 monthly, and then 5. I did the research actually, ironically, about that. And after 5 years of doing biopsies, if no rejection, there is no benefit from doing biopsies after that. But people still continue to do it once yearly after that. So number one, you do it early on. So frequent to catch any early rejection. That's the purpose of biopsy. Is not just what the sake of it. It's the main thing to see that immunosuppressive agents are working and no rejection. If no rejection, you move it, spread it slowly. If there is rejection, you move it back to once a week until you treat the rejection. And that's how it's supposed to be done. So that's that way you save the patient. And just quickly here for Dr. Sam Haley, can you comment on, just for our young colleagues, about very quickly about how to prepare patients, potential complications. We have to go to the basics and make sure that's done right and patient gets out of the table safely and all the measurements are done correctly. Because sometimes you have patients, say severe aortic stenosis with low flow AS, that measurement will be inaccurate to just depend on the bull back. Other example, if you have low ejection fraction or low blood pressure, patient is hypotensive, the measurements sometimes not that accurate. Patient is hypoxic, has a pneumonia or something else. So measurements have to be really in a situation where everything is in line to be accurate. So if you can comment on that, Dr. Sama, just briefly. Dr. Sam Haley, are you still with us? If not, then we'll move it to Dr. Al-Ayyan, Muhammad Al-Ayyan. If you hear, did you hear me, Dr. Al-Ayyan?
Can you repeat it again?
No, sorry, just the basic complications and basic, like when you, for the young physicians, when to do it right. So how to take all the precautions and measurements to do the measurements accurately and also to avoid any complications or potential complications, obviously.
Yeah, I would say for the complication, we need to know the absolute contraindication to do the procedure. I believe first of all, we need to avoid doing right heart cath if we are suspecting endocarditis, right-sided endocarditis. If we are suspecting right-side tumor, so we need to do, most of the time we need to do an echo before the right heart cath. So to exclude these things, so we exclude right-side tumor, we exclude thrombus or anything which can be moved with the catheter. The other relative contraindication, Basem already mentioned that if the patient has left bundle branch block, there is always possibility when you go with the right catheter that you might induce right bundle branch block. So if you have left and you induce right, that means you're going to end up with complete heart block. It's not common, but it can be seen. I've seen it once. So you need to be prepared when you do the right heart cath. You make sure that you're doing for the right indication, and at the same time you need to prepare yourself for any possible complete heart block when you have left bundle branch block to begin with. Another thing also, if the patient has mechanical valve, which is not common, but you can see it sometimes, the tricuspid mechanical valve or the pulmonary mechanical valve. So also in this situation, I would rather avoid doing the right heart cath. Also, sometimes if the patient had recent pulmonary embolism, especially if it's saddle embolism and you treat it conservatively, probably it should be avoided in the first few weeks after the pulmonary embolism incident. Those are important points to remember. Also, as the other common sense, you need to be under complete sterilization, so you avoid infection because you are going into the heart. You might induce infective endocarditis if you are not careful. If the patient had coagulability, especially if you have severe thrombocytopenia, or you need to be careful too. If the patient is on warfarin, especially if you're going to the femoral or something. So you need to use the ultrasound in these cases to avoid any bleeding complications. Also, as I mentioned, always make sure that the balloon is up when you're in the ventricle to avoid any dysarrhythmias. Those are important points to remember, I think.
Thank you, Muhammad. I think that's enough. It's a long list, but I think you summarized it nicely, and definitely you need to be careful and do whatever possible to prevent any complications. Dr. Sam Haley, if you hear me, can you briefly, Dr. Haley, comment on how to differentiate between constructive versus restrictive cardiomyopathy via right heart cath? Just briefly.
Thanks a lot. هو كنت أنا muted لكن هو بالنسبة لنا أهم شيء اللي هو equalization of pressure between the 4 chambers اللي هو في end diastole, which is the hallmark of differentiation between constrictive and any other disease. So we have to have right and left heart catheterization, and if we have this equalization of pressure in the between the left and the right in the end diastole, this is the 1 point in favoring of constrictive pericarditis. And the second point, which is already mentioned by Basem, which is the ventricular interdependence, which is the difference or the mobilization of the interventricular system during inspiration. And this is the characteristic for the constrictive pericarditis, which is diagnostic for presence of diastolic interventricular dependence, and this is the hallmark or the pathognomonic feature of the constrictive pericarditis.
Thank you, Dr. Samaya. So the main thing, as you mentioned, is the so-called concordance versus discordance of the pressures. So the ventricle, right ventricle, left ventricle, you measure them together. The pressures go up together slowly. That's constriction. If the pressure of the right ventricle goes down, the ventricle, opposite to the left ventricle, that's constriction, because there is no room to move for the ventricle, because in the case of constriction, because the solid, thick pericardium, whereas the restrictive is actually muscular disease. It's the muscle itself. It's not affecting. It's not the side outside of the heart. So these signs that we mentioned earlier, like square root and increase the ABD and increase the pulmonary pressure. So, for example, pulmonary pressure will be high in the constriction, more than 55, whereas low, less than 55 in restrictive. And the clinical picture, obviously, if you look at the X-ray, there's calcification. If you have history of pericarditis or radiation, things like that, that will help in addition to the right heart cath. So that way, I will take who is next, Dr. Dayoub. Do you have another question, Adil? Please go ahead.
Yes, thanks, Abdulghani. Interesting discussion. A lot of learning today. So to go back to Rida's comment, I think for us, we're trying to move away from using the SWAN for monitoring. And as a routine now, most of patients, unless there's contraindication, we use a TE instead. So if in my practice, if I have a TE probe, I don't use a SWAN in straightforward cases. The other thing, I think I'm aware of some modalities where they can use the Artline waveform, hook it up to a special device for continuous monitoring for cardiac output in the ICU setting and intraoperative, but we don't have it. I think we are I think it is experimental. It's been used in other centers, but I don't think we use any other way other than SWAN or TE for hemodynamic monitoring. The other comment I want to make is for those who comes to me, especially with valve disease, and a lot of these guys usually have pulmonary hypertension, especially the mitral cases. Unfortunately, the pulmonary hypertension in echo is not always well documented, either because of inadequate tricuspid, like a TR jet, or maybe it's not really detailed echo. And you have a SWAN in the operating room and you find like the PA pressure is like 68/37, or so it's at least moderate to severe pulmonary hypertension. In those cases, what I do usually, there's always pretty much most of them, they come with heart failure. There's bilateral pleural effusions. So by the time you suck 1 liter of fluid from each side, and I always give inhaled Merinone. And I was always impressed by the response. By the time you finish the case, even before you actually finish the case, before even go on pump, the PA pressure drops by 10-15 because you relieve the hypoxia and you actually give a pulmonary vasodilator systemically, in the pulmonary circulation without impacting blood pressure. Because usually in those patients, you worry if you give too much Merinone induces hypotension. But if we give it down the ET tube via nebulizer, so I take either 5 to 10 milligrams of Merinone, mix it with saline, and give it down the ET tube, there's always a nice response, and it gives you a lot of a good idea about how reversible that pulmonary hypertension. That is pretty much what I want to talk about, things related to pulmonary hypertension, right side heart cath from the surgical perspective.
Thank you very much, Dr. Adil. Dr. Mehdi, you have another question or comment? Please unmute yourself.
Actually, very quick comment. I think
Sure.
I understood the people or somebody asked why we take too many cardiac biopsies early on. This is really came from several studies in kidney, liver, pancreas, as well as the heart transplant, that in the majority of the organs, about 80 to 90% of the acute rejections do happen in the first 90 days. And when you look at the heart, the acute rejection correlates very well with the coronary artery disease and structural changes in the blood supply to the heart. So it's really serious complication, where in the kidney, yeah, you may have increased creatinine and you treat it and the creatinine comes back and is reversed. And same thing with the liver, a little bit more difficult with the pancreas. So that's why the biopsies are more frequent in the first 3 months, and especially more frequent in the first month following the cardiac transplant. That's all I just want to say.
Thank you very much. That's very helpful comments. Thank you. I agree with all of those, and definitely the biopsy at the beginning is very important to measure the degree of rejection and to treat it early on. Otherwise, you may lose the graft, and later on, every rejection, as Dr. Hamas mentioned, that will affect the cardiac muscle itself and the coronary arteries, because there is specific, just like diabetic coronary artery disease, there is transplantation coronary artery disease, which is rejection related. The coronary arteries become very thick and like thread-like later on. You can't even stent them. I think that's what Dr. Hamas tried to mention, and I totally agree with you. Thank you very much. Okay, I think, do we have any other questions, guys?
Ghani, for the comments, there's some comments there. There's one by Dr. Idris Suku that he says you can measure the mixed saturation directly without any formulas by blood sampling from the tip of the swan. So yeah, the mixed venous oxygen can be measured directly from the tip of the swan from the pulmonary artery, because the blood has been mixed up and sent up there. But if you're trying to measure it in the right atrium, where are you measuring it? Are you going to measure it high, closer to the SVC, low, closer to the IVC, in the middle where the shunt is? There's really no good spot to measure blood sample for mixed venous O2 sat when you're dealing with a shunt. So if it's a shunt with the where you're trying to calculate the QPQS, then you really need to do the IVC and SVC and use the Flan equation. You can't. There's no real spot where you can accurately measure a blood sample and say that's the mixed venous. That's the problem, where this is where the equation goes in. But in a normal circulation without any shunts, the mixed venous is the same as the pulmonary artery. So you take a sample from the pulmonary artery and you got your mixed venous.
Great. Thank you very much, Basem. Excellent comments. Any other questions? Please raise your hands. If not, then I'm going to ask you, Basem, just to say your final comments, and then Dr. Sam Haley and Dr. Muhammad Layan after that, and then we'll wrap up after that. Please, Basem, any other comments you have?
Yeah, طبعا الشرح comments يعني explain further. It's not clear. هذه موضوع دسم شويه وفيها فيزيولوجي. اذا كان عندكم اي اسئله وحاجه مش واضحه، طبعا المحاضره حتكون متسجله ان شاء الله في الويب سايت في اليوتيوب شانل. واذا كان اي حد عنده اسئله، انا موجود على الفايبر، على الفيسبوك، ما عنديش اي اشكال، ابعتوا لي مسج او نحاول نشرح لكم one on one if I have to، يعني ما فيش مشكله. اسم القناه
Living Cardiac Society. Website, you'll find it. And I think Dr. Ayman Smeir already shared it with us to the Viber, if you are with us in the Viber, or you'll find it on YouTube. Just type the name of the title of the presentation. I already wrote the title of the presentation. Write it down in YouTube and you'll find it, inshallah, after this lecture.
والlecture عبارة عن introduction، يعني you have to read about it or go over the summaries, or feel lots of resources available.
Definitely, it's excellent presentation, Dr. Basem. Really, you did a great job. I enjoyed listening to it, and you did excellent summary. It's not an easy topic, but you summarized everything nicely. You can't cover everything, obviously, but you covered most of the important points that we're looking for, and definitely everybody enjoyed and most likely learned from it. Definitely need to learn more and practice. This is a technical lecture, so you learn and you practice with your hands. This is important. Okay, Dr. Basem Elbarouni, can you mention your final comments, or if you have any other comments, please? مشهور بسام انت supposed to be co-host سام شكلك طلعت وخشيت.
يس اسف جدا ان
لا ولا يهمك ولا يهمك. Go ahead.
في النهايه نشكر الدكتور باسم. it was very nice lecture الحقيقه. هي بدايه زي ما قلت انت للواحد يتعلم الرايت هارت كاتيترايزيشن. المسج اعتقد المهمه جدا بالنسبه لنا احنا في ليبيا ان احنا we have to do more and more right heart catheterization for our patients. And a lot of patients with pulmonary hypertension either can primary or secondary they need comprehensive diagnosis عن طريق الرايت heart catheterization. فيها technical difficulties صح مضبوط، لكن we have to do it more and more especially for diagnosis and for further evaluation of our patients with short and شكرا باسم بارك الله فيك.
Excellent. Thank you very much, Dr. Hilly. Dr. Mohammed Ayan, if you can say final comments.
Yes. احنا تو في الوقت هذا نديروا في البيزك سيريس، يعني نبي نطمن الناس ان احنا ان شاء الله في الفيوتشر حنديروا مور ادفانسد سيريس. يعني التوبك هذا فيري لونج توبك، يعني حنقسموهم باذن الله. يعني مثلا البيزك بتاع رايت هارت كات حتكون ممكن تكون ليكتشر بروحها، وبعدين يعني مثلا الفالف هيموداينامكس بروحها، مثلا الهوكم مثلا والاورتيك ستينوسيس حتكون بروحها. فان شاء الله في المستقبل حنحاول نديروا مثلا مور ادفانسد سيريس، يعني يعني اللي ما قدرش يفهم تو ان شاء الله في المستقبل يعني حيتضح الامور اكثر يعني باذن الله.
Inshallah. Excellent comments, everybody. Excellent talk. Basem, well done. I really appreciate the time and effort you had to prepare for this excellent presentation. I really appreciate the audience. It's excellent to have all of you and nice to have all of you. All excellent comments from the audience and excellent questions. So from here, I would like to thank you again, everybody, and we'll see you inshallah next time. Assalamu alaikum.